Thank you, sir. Thanks for your kind words of introductions. Good morning. I need a couple of acknowledgements I need to do. First of all, I thank the FeFCon organizing team. Keep on having faith in me in last 3 to 4 years for conducting this morning breakfast sessions. I need to thank the FeFCon organizing team as well as the advisory board members for giving this enormous responsibility. One, and I need to thank Microlabs for providing this opportunity. Third thing I really missed today, my co-participant, Dr. Bhaskar, I said, he made this even more participant, more successful. Unfortunately, I missed him. So he put double the responsibility on me. Usually 50-50 will take the responsibility. Today, he put my 100% responsibility on me. So I need to sincerely acknowledge Dr. Bhaskar sir for making this even more successful there. With this words of introductions, I'll just start sharing my slides. I hope it will display without any hitch. I think it is displaying. It's in the...
Yes, sir.
Yes, sir, visible, correct.
Okay, thanks. Thank you. So I thank again the chairpersons for the kind words of introductions. Actually, I told Dr. Manjula to name it's no antibiotics. Always in English, KNOW and no antibiotics is always difficult thing. So antibiotics in OP is no to me. That's why I said no, NO, no antibiotics. But somewhat it went into KNOWO. So I made no or no antibiotics in OP. When to start, what to start, why not to start. This is my aim today. So disclosures, nothing. I don't have any disclosures pertaining to this talk. I'm clean on this. And one more disclosures, I am married. Because of married, I don't have money in my pocket. We deal with a lot of resistance and lot of stuffed situations in our day-to-day practice that give a lot of confidence to manage any situations in our antibiotic selections and antibiotic pressure monitoring. I'll straight away open this poll to the participants. This is a poll question there. In which situations you will start antibiotic? I'll ask my organizing team to run the poll. This is a 10-year-old boy because my co-participant, Dr. Bhaskar Shanai, was not there. So I'll put one of the child case also here. 10-year-old male child, fever, sore throat, running nose, congested throat for the last 3 days. This is during the COVID time. Just now you think about it. 60-year-old female, diabetic, poorly controlled, urine routine showing plenty of pus cells, culture showed 10 to the power of 5 E. coli. 30-year-old male, diarrhea, 5 times watery and nausea of 2 days durations. 50-year-old female, bilateral leg swelling and redness. I'll show pictures subsequently during my presentations. And 20-year-old female, planning root canal procedures. So I'll give the choices also. Only diabetic host need antibiotics, or diabetic plus 50 plus leg swelling need antibiotic. Except one, pediatric doesn't need antibiotics, so only adult need antibiotic. What do you think about it? Or all of the above? Always in multiple choice questions, the all of the above, none of the above is always tempting to you. So think about which one you want to go for it. Please go ahead and vote. I think the poll is running. Organizing team, correct?
Yes, sir.
Wait for 10 seconds. Yeah.
They have to use the chat box for poll?
No, they need to answer.
RX events. Yeah, RX events.
Ma'am, there is a poll button.
Okay.
So I'll wait for 10 more seconds or 15 more seconds for first question. Subsequently, once the first question is taken over, we need to check. So this is a first question. So I'm waiting for 10-15 seconds before starting.
Somebody, can you give the instruction to the delegates where that poll button is so that they will use it? Yeah, it's clear. Yeah.
Okay. So the poll is running now.
Yes, sir.
Okay, good. But I do not know whether I'm going to see the response or only the audience will see the response. If you are able to see Dr. Manjula, you can update me the response. Okay. So far,
Yeah.
my questions only there.
Sir, I can see only 2 is 25%, 2 and 4 is 75%, rest all 0%.
Okay.
Yeah.
So fine. So suppose if you want to start antibiotic, people who answered the poll, I want to start antibiotic for this scenario. For example, this 10-year-old male child, what antibiotic you would start? Amoxicillin or amoxiclav, or you want to start fluoroquinolone, Cipro or macrolide in the form of azithro or claritro, or you want to start clindamycin, or you want to start cefuroxime or cephaloxime. What do you want to start for 10-year-old child? And for a diabetic lady with urinary tract infections, which is your preferred choice? Cipro, Norflox, or you want to start cefuroxime, cephaloxime, or amoxiclav? For a diarrhea, which one? Norflox plus tridazole or Ciplox plus tridazole, what do you want? And for a patient with bilateral leg swelling, what is your preferred antibiotic? So what is your preferred antibiotic? In other words, amoxicillin or norfloxacin or linezolid or cephaloxime, cephalosporins, which is your preferred antibiotic in OP settings? That is my question. So no antibiotic. What you are preferring it right now?
Poll has to come, please.
Very good. I'm able to see the situations now. Fine, good. Okay, the next questions, which antibiotic will you start? Antibiotics. Okay, I need to share my screen again. Okay, good, that's fine, no problem. I am comfortable with this one. Okay, sure. Okay, so people who answered why no antibiotic? Why no antibiotic? Most of the antibiotic, this is a third poll questions for you. Why you don't want antibiotic? Most of the OP infections will settle on its own. Most of the infections in OP are due to virus. Antibiotics causes a lot of side effects. That's why I don't want antibiotics. This is no antibiotic sessions. So we need not write antibiotic as a choice or I don't know. Which one you're preferring to go for it? Please go ahead and vote. Why no antibiotic? You're saying I don't want to write antibiotic. But usually this will happen in conference. But in real life scenario, this is not happening there. Conference people say I don't want antibiotic. At least you tell what is your reasons you don't want to start antibiotics. Most of the infections are settled on its own, or most of the infections are viral, or antibiotic has low side effects. Because you think it's viral, or because of the side effects, or because of the cost. Can I see the results, or can Dr. Manjula can read out?
No, can you open the poll? I am not seeing the poll. If you can see RX events. Can you open the poll, please?
After this question, a lot of time will be there, so people can take time there because I run
Yeah.
3 questions immediately. Then I want to go for a theory
Session. Yeah. RX event, can you put the third question poll? Or it is already done. Please show the results.
Why no antibiotics? That's my question there. Okay. Still, it's getting ready. I can move on the thing, and Dr. Manjula will update me afterwards there. So I move on my next turn. So we need to remember William Osler quote. Suppose if we start some medications, always keep in mind the patient need to recover from two things. One, from the disease, what he suffer. The second thing, what the medications you are giving to the patients, he need to recover from the medications. Medications are all not safe. Whatever medicines you can call, whatever medicines is not safe. So always think two things, whether the patient need to suffer from the disease and recover, or whether the patient recover from the disease and suffer from the medications what you prescribe and suffer from the medications and recover. If you keep this in mind, you don't write unnecessary antibiotics or unnecessary medications in your practice. That is the moral of the story for today's workshop. So my objective today, why no antibiotic sessions for FeFCon 2022? Then when to start, what to start, when not to start, and summarize at the end of the thing. So why we need this workshop? A couple of slides there. So this is good, interesting paper from JAMA 2016. 1 in 2 outpatients are getting antibiotics in OPD. Even though this is a US-based study, in the US it's 1 in 2, means in India, I think 2 in 2 for me. And respiratory tract infections is a leading cause of antibiotics. In India also, the respiratory tract infection is a leading cause of antibiotic. And most of the prescriptions were inappropriate. That is why we are conducting these sessions to make your antibiotic choice correct. And most of the time, we don't want antibiotics. People answered no antibiotics for most of the situations. But if I do OP antibiotic prescription audit, if I come and sit in your OPD and collect the prescriptions what you are giving, I started collecting a lot of antibiotics. For example, even during the time of COVID, people used azithromycin. In fact, healthcare personnel, you suffered COVID and you have taken azithromycin, doxycycline, ivermectin. So you are yourself taking a lot of antibiotics. This is a problem. So people want to take viral infections also, they want to write. They write viral fever, but below the viral fever, some antibiotic prescription is present. So this is called antibiotic audit. During the time of meeting, you say there is no need for antibiotic, but in real practice scenario, it is quite different. So we need to do a lot of audits for you people. And this is inpatient setting, even more worse. People start sending some cultures, reacting to the cultures. Whether the patient is having fever or not fever, this is one of the hospitals. The patient is absolutely not having fever, but keep on sending cultures. But the WBC count is high, when procalcitonin is very high, they keep on sending the cultures, keep on sending the procalcitonin, based upon the WBC count, based upon the procalcitonin, based upon the culture result, wound swab, drain fluid, they start reacting the antibiotics. See the cost of the antibiotic, how much suffers. If you read the William Osler, the patient should recover from the disease. Already the patient recovered. Unfortunately, because of your medication is suffering now. People say dengue. For example, we did the audit for dengue patients who came to the OPD. Out of 180 hot patients in the dengue, most of the patients getting antibiotic. Most of the patients getting antibiotic. So this is a prescriptions for dengue. Before making a diagnosis, at least you say, I think the patient has got typhoid. I give an antibiotic, that's fine. But once you made the diagnosis of dengue and the serology report is also dengue, what is the point in writing antibiotics? But if you do the audit, people are using antibiotics for dengue patients, even after the diagnosis. So don't say, like, I don't write antibiotics. We are not believing a thing. Then what is a big deal? So what? If I write antibiotic, you'll ask, I write antibiotic. What is a big deal? If you see, this is a first case of antibiotic success shown in the literature. For example, this child presented with severe necrotizing fasciitis. All intervention tried before 1940. None of the interventions worked. Only penicillin came into the market, the child improved well. This gives confidence to the World War soldiers too. In World War I, there is no antibiotics, so people suffered and died. But during World War II, penicillin came into the market, go and fight, whatever wound you are suffering, you're going to come back. So what gave the confidence? The industry started producing a lot of antibiotic between 1940s and 1970s. To be precise, 1942 to 1970, the life expectancy gone by 7 years. Life expectancy gone by 7 years. No other public interventions, no other public health interventions improved the life expectancy. For example, providing clean water, vaccines, not improved within a short span. Yes, they improved the life expectancy, but not within a 3 decades. That is more important. What happened? It gave a lot of confidence or overconfidence. The Surgeon General Stewart, he told US Assembly, we won the battle. We got vaccines for the diseases. We got infections, antibiotic for the infections. There is no need for further thing. By 2000, all viruses and bacteria have been eradicated. This is a statement he made in CDC in 1968. We need to search for this man, William Stewart, in the heaven and bring him and show the status what we suffered in 2020, 2021, and 2022. So this is a statement he made. So what happened? A lot of antibiotic they introduced in 70s, but after the famous quote from CDC in Central General, the chief surgeon to the CDC, people suffered. Antibiotic has not come into the market. At the same time, whatever antibiotic introduced, people start abusing the antibiotic or using the antibiotic. As a result, what happened? Bacteria start taking revenge on us. They start producing resistance mechanisms. The resistance mechanisms wash out whatever antibiotic is existing in policy. So almost all the antibiotics started developing resistance. So there is no antibiotic to treat at this point of time now. This is a backstory. So people say, where is the evidence? You are saying about antibiotics are resistant. Yes. So this is an antibiotic resistance scenario. This is a busy slide. But see the column. When a patient has got colistin resistance bacteria, colistin is an old antibiotic reintroduced in 2008 because there is no antibiotic. It is a nephrotoxic antibiotic. We introduced a nephrotoxic antibiotic in 2008. In 2015, what happened? The patients start developing colistin resistance bacteria. Once you got the resistant bacteria, you're not going back home. You're not going back home. All are expired, lost to follow. And a lot of English medias and Facebook journals start saying that Indian physician does not know or Indian pediatrician does not know how to treat infections. Because we are abusing antibiotics, we do not know the resistance mechanisms. And even in Pakistan, typhoid is resistant to ceftriaxone. We need to use carbapenem like imipenem, meropenem to treat typhoid. So this is a status we are also landing in. Don't think Pakistan only the situation is bad. Indian situation is also equally bad. Not only think about the antibiotic resistance and antibiotic death, but adverse events. Antibiotic, I told, that's why William Osler told, think twice before writing some medications. The patient need to recover from the disease and recover from the medicines. Antibiotics are all causing adverse event. US has got very good data system because they got very good electronic health records. They tracked. Patient comes to the emergency department, particularly patient got discharged with antibiotic, came back to the emergency department. This is quite common. I'll show the other case scenario here. 28-year-old female, no comorbids, burning micturations and urgency, chory-hematuria, but no fever. Lower abdominal pain is present, and on examination, tenderness is present over the suprapubic region. Urine routine showed plenty of pus cells. What antibiotic would you start now? Please go ahead and vote. I can run the show this time, hopefully. Organizers, please check. So last question they answered, why no antibiotic? I don't know. So people need to learn. That's why they're attending the workshop. Very good reason. That's a top reason there. Very good. So for these questions, please run the poll again. I need to share the questions and meantime run the poll. What antibiotic you would prefer for this young lady with urinary tract infection suspected because she got burning micturations, urgency, cori hematuria, and suprapubic tenderness? Can I see the poll results? Or poll is running?
So there are two answers only, 50% phosphomycin, 50%. Actually, there is a mistake in the poll RX event. The last option should have been no antibiotic still culture, but it is showing both phosphomycin. That's
Okay,
why
no
it's coming
problem.
50-50.
Okay. So people given antibiotic choices means that's the best thing there. Fine.
Yeah, right, sir.
So you can stop the sharing. I can start sharing my screen.
Yes.
Yeah. Okay. So it's good. At least I can able to feel what the audience is feeling. Hereafter, no need to show Dr. Manjula will help me out there, so I can finish on time.
Okay, right.
Okay. Fine. So this is the result. This is a urine culture report. Almost all the antibiotic is resistant except amikacin, that too intermediate. So this is not a cooked up situation. This is all real situations people are facing. This is a young female, no antibiotic exposure, no hospitalizations. Previously in 1990s and 2000, when a patient comes with urinary tract infections, start one dose of norfloxacin. They themselves go to the pharmacy, get one dose of norfloxacin, urinary tract infection subsided. But in 2021, 2022, even powerful antibiotic like meropenem, imipenem, colistin is not working. This is the same scenario for pediatricians also. They got a lot of antibiotic using, and even I got a discussions yesterday on pediatric urologist. He says 1.5-month-old child come for hydrohydronephrosis surgery. The child is having no symptoms, basically hydrohydronephrosis. So you want to do a neurological procedures. Before starting a neurological procedures, he did the urine cultures and urine routine. Urine routine showed pustules and urine routine showing culture is growing, E. coli 10 to the power of 5, resistant to everything. 1.5-month-old child, not even exposed to a lot of antibiotics. 1.5-month child, carbapenem resistance E. coli, carbapenem resistance Klebsiella. He's asking me, previously I used to give simple antibiotic like nitrofurantoin to take care of this one, but I'm now suffering. I don't have antibiotic to give prophylaxis. I'm worried whether I need to go ahead and operate or not. You need to plan for pyeloplasty and you need to plan stenting or something. And he says it's very difficult for me. I'm giving antibiotics. What antibiotics? I do not know. This is a status I'm living in. So this is a real scenario. Don't think this is a cooked up scenario. This is a real scenario. People are facing it up. That is why we arrange the sessions of no antibiotics in your OPD setting. So why so much of antibiotic therapy? Why so much? People always think they need to treat infections immediately. If you don't treat infections, the infections will kill you. This is a myth, I can put it. Cultures are difficult to grow. If you ask, cultures will take 48 hours, difficult to grow, not growing all the time. And provider belief. Well, provider belief is a main reason because this was not taught in our undergraduations and post-graduations how to choose antibiotic. We just copied the prescriptions of my chief or my professor, what he used to write. He just copied. Why he chosen this antibiotic, I do not know. He didn't tell me what is a rational. In the examination, they didn't ask how to choose antibiotic in a case scenario. They want to find out mitral stenosis. They want to find out stroke, where is the lesions. But they didn't know where is a site of infections and what antibiotic they didn't teach us during my undergraduations and post-graduations. Fear, always fear, because my practice is busy. I'm missing something, just give antibiotic to cover whatever missing I'm thinking. Myth, anti-inflammatory. Why doxycycline in dengue? Anti-inflammatory. Why azithromycin in COVID? No data. They are getting better. I use these medications for the last patients. He improved like ritual. When a cricketer scores 100 with the whole bat, they want to see the sun and they want to use the same bat till the bat is broken. So they want to use the same bat. So this is a scenario people are using it. So basically the habits are difficult to change. Habits are difficult to change. The second most important thing, lack of knowledge. And third thing, lack of control or aggressive marketing, maybe, but fortunately the organizers don't do aggressive marketing. They give freedom to talk as well as freedom to discuss anything. So this is another thing, lack of knowledge and habits is most difficult. Particularly lack of knowledge is there evidence people asking? Yes, we put the paper. I told E. coli resistant to carbapenem in 2008, but people still do not know whether carbapenem is working. What is the resistance mechanisms? That's called NDM1. I asked Indian physicians what is NDM1. They're not aware. In 2012, we are repeating the same study in 2022, whether they still know what is NDM1 or CRE. We are checking for it. So that's why we conducted one of the CME called No Antibiotics, dedicated antibiotic CME. Whatever antibiotics you are using in OPD, with all the experts we conducted in the month of August. Right now, the content is available. We can, if you want to learn more of antibiotics, need to learn this antibiotic sessions individually. It's going to upload it soon. So I'll come back to the workshop now. So I provided a background. Antibiotic abuse is common in OPD setting. Why? Lack of knowledge, or because of the peer pressures, or because of the other reasons. So we need to know antibiotics. For example, this is a case here. I think the organizers can run the show back, and once I finish this slide, Dr. Manjula can answer what is the answer for this one. 25-year-old female, sore throat, cough, fever. Fever is not great, 99.4 to 99.6, 3 days durations. On examination, the throat is congested, not a sick look. Chest is clear, few small cervical node. What antibiotic will start? Erythromycin, ofloxacin, ciprofloxacin, or amoxicillin clavulanic acid, cefuroxime, cephaloxacin. What is your preferred antibiotic? Or you think, no, this is choice is missing, I'll write something. Please go ahead and vote, so that at the end of my slide, Dr. Manjula will tell me. So what is your choice? I hope the slide is running, the poll is running.
Yeah, yes, sir. It's
okay.
running.
So I'll show them my theory. Yeah. Okay. So to increase appropriate antibiotic, what you need to do? I'm saying no antibiotics, but what you need to know? First thing, we need to define the infections in 2 ways. One, anatomically, where is the infections? Whether it's infections in the brain, infections in the heart, infections in the lung, infections in the kidney, or infections in the skin and soft tissue. Once you know where is the infections anatomically, we need to define the infections microbiologically, whether it's caused by gram positive, gram negative, or anaerobe. Because bacteria only 3 things: positive, negative, anaerobes. When to think positive? Any infections happening above the diaphragm. Always put your money on gram positive. This is OPD setting. I'm not talking about inpatient setting. For example, meningitis. What causes meningitis? Streptococci is going to cause meningitis. Similarly, pneumonia. Either streptococci or staphylococci is going to cause the pneumonia. Infective endocarditis. Staph enterococci is all possible. Below diaphragm, put your money on gram negative. Urinary tract infections. What is going to cause? E. coli, Klebsiella. What is going to cause intra-abdominal infections? Either E. coli, Klebsiella, gram negative, plus or minus anaerobic organisms. So we need to think about microbiologically, means whether the bacteria is going to be gram positive, gram negative, or anaerobe. Where is the lesions? Whether it's brain, heart, lung, skin, soft tissue, pharynx, sinus, ear. Think about it. Think the organ, which organ is affecting? Ear is affecting, sinus is affected, pharynx is affected, lung is affected. Think about it. Skin and soft tissue, bone, joint. Think about anatomical locations. Suppose if you got some rapid diagnostics is possible, you can use a rapid diagnostic, but rapid diagnostic is not always the answer. But always make a courage to make a diagnosis. What is your diagnosis? Don't write just treatment alone in your prescriptions. Please, what you think, commit in your prescription paper. Do not solely response to therapy. Somebody is taking medicines, don't think the response happening because of the medications. That is a false myth. Because of the immunity or because the infection is not present, the patient is improving. All is possible. If empirical therapy started because your doubt, you started some therapy, always reassess in 48 to 72 hours. So this will increase your antibiotic choice. If you don't want to remember these things, at least write a diagnosis. What is a diagnosis? I'm thinking. Write anatomical diagnosis, write your microbiological diagnosis. Dr. Manjula, what has happened to the previous?
Yes. Yeah, pool is running. Erythromycin 11%. I think Hardik's team can show. Ofloxacin 0, amoxiclav 11, and last option 77%.
So people are wondering what to use there. So that's a good thing. So what to make syndrome? We need to make a syndrome. So instead of making a diagnosis, I do not know exact. For example, I'll come back to this case a bit later. So make a syndrome similar to the HTD physicians. They always say genital ulcer syndrome, genital discharge syndrome, genital lymph gland syndrome, or genital swelling syndrome. That's what they made. Similarly, you also think fever, cough, sore throat. What syndrome? Pharyngitis or pharyngolaryngitis is possible, or pharyngolaryngitis plus tonsillitis is present. On the other hand, fever, dysuria, burning sensations, think of urinary tract infections. Presence of fever, swelling, redness, cellulitis, fever, diarrhea, vomiting, think of gastroenteritis. So some syndrome we can make. So there's no need to worry about exact diagnosis. I don't want to say it's a group A beta hemolytic streptococci causing pharyngitis for everybody. At least write the syndrome in your diagnosis. Then third thing is we need to know whether the patient is sick or whether the patient is stable. How to assess the stability? Check the vital parameters. When the vital parameters are normal, he's able to give conscious, able to give history, able to come walking to your OPD settings, and patient is able to give history, and patient is sitting, taking bath, taking food, means the patient is stable. Nothing else. Don't use any advanced scoring system. Assess the patient, whether he's brought in the wheelchair or whether the patient is giving own history, what is his vital parameter. Then try to localize. As I told earlier, any anatomy you can able to localize. Brain, heart, lung, pharynx, sinus, ear, think about it. If you are not able to localize, you follow the other tropical infection stuff. So system, we need to require antibiotics. Then we need to certain system. For example, if you identify system, infections you are thinking in the brain, there is an infections, probable brain, I don't want to wait. We need to take appropriate samples and start antibiotic. Similarly, urinary tract infections, viruses causing urinary tract infections, only post-transplant setting is possible. For immunocompetent, the chances of bacteria is more likely causing urinary tract infections. By viruses won't cause infections. Skin and soft tissue infections, progressive in nature, most probably bacteria. So these are all the syndrome requires some antibiotic. On the other hand, respiratory tract infections, mostly virus. Similarly, gastroenteritis, mostly virus. So what are all the syndrome we can wait and what are all the syndrome we need to proceed, we need to know. So coming back to this case, the patient has got fever, cough, and sore throat. My syndrome is pharyngitis or pharyngotonsillitis here. I need to go with to decide which bacteria or which virus is causing. One score is called CENTA score. What is a CENTA score? The patient is stable. The patient is not unstable to me. And I try to localize anatomically to the pharynx or pharyngotonsillar region. I'm able to localize this man. So what causes pharyngitis? What causes pharyngotonsillitis? Virus. Common conditions, always think common. Pharyngitis means viruses. Mostly viruses causing pharyngitis and pharyngotonsillitis. One bacteria we worried about is called group A beta hemolytic streptococci. But always think whether the patient is life-threatening infections or not, whether he abscess, any epiglottitis, peritonsillar abscess, think about it. And always think broad, not only infection is going to cause, microbiologically we need to define whether it's an infections or non-infections. If it is infections only, bacteria, virus, parasite, in the bacteria, positive, negative, and narrow. But other conditions also mimic infections, always think broad. So how to differentiate? Use the CENTA criteria. What is CENTA criteria? 4 criteria. Presence of high-grade fever, bacteria. Presence of cough, virus. Presence of purulent tonsils or purulent exudate from the throat, bacteria. Presence of tender node, bacteria. So if you use this criteria, we can say whether the patient is bacteria or virus. That's called CENTA criteria. Based upon the CENTA criteria, here the patient has got fever, that too low-grade fever, not high-grade fever, small node that's not tender, throat is congested but not purulent exudate, and there is presence of cough. All indicate the patient has got viral fever. There is no antibiotic is the best answer here. So that's what we need to do. Use the criteria. Suppose if you think the patient has got group A beta hemolytic streptococci, what antibiotic? So this chart we need to remember. For example, in streptococci, what are all the antibiotics will work? Antibiotics in green has got very good effect. Antibiotics in dark blue may work, may not work. Antibiotics in light blue, most of the time will not work. So for example, for a streptococcal infections, what are all the better drug? Penicillin is a better drug. Third generation cephalosporin is a better drug. Ampi and amoxicillin is a better drug. And even first generation second generation cephalosporin is a better drug. Third generation cephalosporin, yes, is okay. So these are all the things we need to think about it. So this is called antibiotic spectrum. What is a bacteria? Streptococci. What antibiotic will work for it? Gram-positive agents. What is a gram-positive agents? Penicillin is a gram-positive. First generation, second generation cephalosporin is a gram-positive. Amoxicillin is a gram-positive. Among the thing narrowest is penicillin. You can use penicillin. That's a better choice. Antibiotic delay. Then you need to know whether suppose you are not sure about it, whether I can wait without antibiotic. Yes, it is possible. Certain infections like acute bronchitis, otitis media, upper respiratory tract infections, pharyngitis. Yes, these things you can wait. I told earlier, meningitis, meningoencephalitis, proven case of urinary tract infections, along with progressive skin and soft tissue infections, we need to start antibiotics. Other infections, you need to wait. Suppose you start antibiotics, always the mantra is short. For example, community acquired pneumonia. I'm not talking about upper respiratory. I'm talking about lower respiratory tract infections. The duration nowadays is 3 to 5 days, not more than 5 days. So that's the recommendations for pneumonia syndrome itself. So think about it. If you start antibiotic, short is sweet, long is not required. Short is sweet, short to clear the bacteria, short to prevent the resistance. That's a mantra. If you start putting the antibiotic, the bacteria got irritated. Once it got irritated, it produces resistance mechanism. Simple. So keep it short. So I'll move to the second common syndrome in your practice. You can run the poll simultaneously. Who is suffering from UTI? Doctor, one of the complaint. Of late, my urine is foul smelling. I call it an UTI. 62-year-old male posted for TKR. Urine routine showing bacteria. Ortho, can I proceed? 24-year-old female with complaints of vaginal irritations, pain during sexual activity. Can you call UTI? 34-year-old female, body pain, weakness, fever, urine culture, CRE. Is it UTI? Please go ahead and vote. Which is causing UTI? Which you call is UTI, not which is calling UTI, which you can call UTI. Foul smell urine, or presence of 10 to the power of 5 bacteria in TKR patients, or presence of vaginal irritations and pain during sexual activity, fever, body pain, weakness in urine cultures, but patient is conscious, patient is oriented, but fever, body pain and weakness, and carbapenem resistant enterobacteriaceae. What the culture report I showed a couple of minutes back, the Klebsiella. Please go ahead and vote. I'll see the responses a bit later. Why you need to know the UTI? UTI is one of the common symptoms, particularly for pediatricians, mostly common, because the symptoms like classical dysuria, burning sensations, a child won't tell. Particularly for me, up to the age of 1, because I do pediatric ID also, up to the age of 1 or maximum up to the age of 2, it's very difficult to elicit the history from the child. But if the mother is smart enough, the parents is smart enough, they will recognize. When the child goes to the urine, the child definitely, even if the child voids in the diaper, the mother notices the child will start crying. Even though after passing urine, because of the wetness, they will cry. But while passing urine itself, the child will cry, the urine will struggle. And some of the children, they keep the pain, the hand on the lower part of the tummy. So the parents is smart enough to pick it up whether the child has got some symptoms or not. Otherwise, I'll come back and show the shortcut how to sort out the problem there. So urinary tract infection is most commonly abused antibiotic also. So we need to know whether the patient has got urinary tract infections or not. How to do it? We need to know the symptoms: fever, dysuria, urgency, hematuria. If all the 4 parameters is present, the chances of urinary tract infection is very high. But still, you can't say 100%. But what will say when the patient does not have symptoms? No fever, no dysuria, no urgency, no hematuria, the chances of UTI is almost 99% ruled out. So it has got very good negative predictive value. So we need to check whether fever, dysuria, urgency. Most of the time, the call coming from the house officers, the resident doctors call me, sir, urine culture 10 to the power of 5 E. coli. Just now also a call, I just cut the phone now. They're saying urine culture grew 10 to the power of 5 E. coli. But he didn't say what is the symptoms he's having, why he tested the urine cultures, no informations. So always ask symptom. If the symptoms is not there, 99% of the time, you can rule it out UTI. Then people always confuses with asymptomatic bacteria. What is asymptomatic bacteria? Presence of 10 to the power of 5 bacteria in the urine. Presence of even pus cells also in the urine. But what is missing in asymptomatic bacteria? There is no symptoms. Absolutely no symptoms. For example, the case what I shown previously before the knee replacement. The patient came for knee replacement. Who ordered urine cultures? I do not know. So that is the reason for it. The patient has got symptom that becomes symptomatic UTI. Most of the time, what will happen? Presence of bacteria, 2 or 3 bacteria, poor collections of the urine. That is a reason for antibiotic starting. So we need to know whether it's upper UTI or lower UTI. It's very important. Certain antibiotic will work for lower UTI. Most often you see lower UTI in a female patients in your emergency settings or OPD settings. For example, urgency will be there, hesitancy, hematuria, suprapubic pain. But what differentiates upper UTI and lower UTI? Fever. Fever means upper UTI. Why it is important? I'll come back in a minute now. So in cases of pediatric setting or the presence of confusing history, we are not sure about it. What you need to do, look for pus cells. Look for pus cells in the urine. Look for pus cells in the urine. I'll come back. Look for the pus cells in the urine. If presence of pus cells, the chances of UTI may not be there. But absence of pus cells, what I told, for example, the symptoms, fever, urgency, micturations may not be UTI. But absence of symptoms rules out UTI. Similarly, presence of pus cells, plenty of pus cells may not be UTI, but absence of pus cells rules out UTI. That is a mantra you need to keep. When a patient has got asymptomatic bacteria more than 10 to the power of 5, like similar situations what I shown previously, what we need to do, two situations. I need to treat in the presence of urological intervention. That's why the pediatric urologist is wondering. He got a small child planning for a urological interventions, but culture is growing plenty of pus cells. That is asymptomatic bacteria, but still you want to do the procedure. So he was worried about what antibiotic to start. So any urological procedures, we need to screen and we need to treat before, not treat, at least we need to give prophylaxis for 48 hours before procedures. On the other hand, pregnant woman, even though the asymptomatic bacteria, but we need to demonstrate 2 occasions more than 10 to the power of 5 and pus cells should present, no bacteria. That point of time, yes, we need to treat. Apart from the 2 situations, pregnancy, urological interventions, there is no need to treat asymptomatic. For a patient going for a TKR, patients going for a bypass surgery, don't treat asymptomatic bacteria. Only patients, even renal transplants, we stop treating nowadays. Post-renal transplant bacteria without symptoms, I'm not treating it. So why we should not treat? If you start giving antibiotic, this is an end result. If you start treating the asymptomatic bacteria, this is the end result to the patients. So send appropriate. First thing, the patient should have symptoms. Second thing, we need to send urine routine. Urine routine, pus cells present, symptom presence, ask for urine culture. This will cut down unnecessary testing. If you test unnecessarily, the patient start using unnecessary antibiotic. Then what antibiotic for UTI? We can't cut copy IDSA because the resistance to the gram-negative in US is very less. Similarly, for Europe, it's very less. They can use ciprofloxacin, ofloxacin, norfloxacin because it is working in Europe and US. But in Indian scenario, it's quite different. We can't use the bacteria because our resistance is very high. So once you made an urinary tract infections, urinary tract is anatomically located below diaphragm. So what causes urinary tract? Gram-negative. What is the commonest cause of urinary tract? Enterobacteriaceae. For enterobacteriaceae, what are all the drugs will work? Yes, if the ciprofloxacin, ofloxacin sensitive will work. Cotrimoxazole, nitrofurantoin. So nitrofurantoin is a beautiful drug. It will work most of the time. The resistance is not present, but couple of concerns. One, nitrofurantoin is a good drug for lower UTI. The pharmacokinetics of nitrofurantoin will not allow it to enter in the kidney. Whatever nitrofurantoin, it goes to the bladder, excreted in the kidney. So nitrofurantoin is a good drug for lower UTI like cystitis and urethritis, not for pyelonephritis. But in the presence of elevated creatinine, nitrofurantoin should not be used. That causes any issues. Then other drug called cotrimoxazole. Yes, cotrimoxazole is a very good drug. Unfortunately, cotrimoxazole has got a lot of side effects. For example, potassium we need to monitor, creatinine we need to keep on high, and along with the blood counts also we need to keep on high. And allergic reactions to the sulfa is a concern. So always ask history of allergy to sulfa before start writing cotrimoxazole. What are the drugs? Quinolones is a beautiful drug. You can cut down the durations, but unfortunately resistance in India is almost 85% to 90% of the time. Ciprofloxacin, norfloxacin is not working in my situations. So what we left out, sometimes we need to use aminoglycosides provided the kidney is fine, provided the patient should have UTI. The UTI is there. Ideally, what I need to do, send urine routine, urine cultures, and start antibiotic based upon the local antibiogram, which is the best drug. Nitrofurantoin is a better drug for lower UTI. For upper UTI, either amic acid may be working, provided the kidney functions are good, or we need to use BL-BLI combinations in the form of piptazo or cefoperazone sulbactam. Why? Cefotaxime, ceftriaxone, the resistance is very high. Till the culture is back, we can use it. Once you know the sensitivity, once you know oral drug is working, change over to oral drug. I think year after the urinary tract infection is a child's play for you. So we need to know what antibiotic. If you choose strong antibiotic, the urine will come in other directions rather than what is happening in this picture. So my third case scenario, 30, you can start running the poll. 30-year-old male, Chennai, working in IT, recently married. So he's eating diarrhea, a lot of outside visit event, and he had taken a lot of food. Diarrhea 3 times a day daily. No blood, no mucus, no fever, no vomiting, no abdominal pain. On examinations, hydration is maintaining well. Afebrile. What do you call? Gastroenteritis, dysentery, diarrhea, food poisoning. What is the stool frequency? So what are you going to call now? So we need to make a proper diagnosis. When a patient comes with fever and diarrhea, don't always think the patient has got gastroenteritis, always bacterial. I told 2 situations, respiratory tract infections, gastroenteritis, always you can wait and watch. So make a syndromic diagnosis. Yes, the patient has got no fever, stool frequency 3 times a day. We need to go and ask what is your routine stool frequency, baseline stool frequency. If the baseline stool frequency is 2 to 3 times, it's normal. 3 times a day is normal. 3 times a week is also normal. So think the baseline. Don't immediately jump and start antibiotic. Work on it. The patient is hydrated well, no fever, no nausea, no vomiting. Think about what is his natural history. Got recently married, because of the married, he got tension, and because of the tension, he's passing stools. I'm not sure. So differentiate whether it's a diarrhea versus dysentery. So diarrhea, usually it's probably from the small bowel. How to differentiate whether it's a diarrhea, dysentery, or small bowel from large bowel? Small bowel, less number of frequencies. For example, 5 to 6 times, but the volume is more, large content, because small bowel retain a lot of fluids. So large amount of fluids, 5 to 6 times, no blood and mucus. Fever may not be present, but in large bowel, fever will present, blood and mucus, more frequent time, along with blood is also present. Why this differentiation is needed? Dysentery needs antibiotic. Diarrhea does not need. But patient will come and say, doctor, I got dysentery. What is the stools? Watery stools. How many times pass? 4 to 5 times. So they always say dysentery. Please elicit the history, whether it's a dysentery or diarrhea. Dysentery means presence of fever, presence of the blood, presence of the mucus. More times he is passing, and small quantity of stools. What causes diarrhea? Most of the time viruses. How to differentiate diarrhea versus dysentery, or how to decide antibiotic? Presence of fever needs antibiotic. Presence of blood or presence of mucus in the stool needs the antibiotic. Presence of more than 8 times or more than 10 times needs antibiotic. Rest frequency, hydrated, no fever, watery stools, mostly virus, don't need for antibiotics. If you read the guidelines are changing. Even the Western guidelines, what is a preferred antibiotic? People always want to use Norflox TZ, Ciplox TZ. There is no role of parasitic infections. For example, amoebiasis, giardiasis, most of the time is a subacute, particularly amoebiasis subacute. Giardiasis, the chances of having giardiasis is very, very less common, mostly virus, bacteria. So people always want to use Cipro, Norflox, they want to use it. But Cipro or Norflox resistance is going up, particularly for Campylobacter. Common causes of organisms in loose stools, gram-negative, Salmonella, Shigella, Campylobacter. So fluoroquinolone resistance can go up. Rifaximin only for traveler's diarrhea. So what is a better drug? Azithromycin is a better drug. According to the data, it has action against Salmonella, it has action against Shigella, Campylobacter, Yersinia, and Vibrio cholerae. All 5 is taken care with azithromycin. You can use azithromycin. People say azithromycin can cause diarrhea. Yes, we need to use sometime the patients causing diarrhea that will taken care. So acute gastroenteritis, oral rehydration is a therapy. Ensure the hydration, that is more important. Second thing people want to know about probiotics. In pediatric, yet it's got role, but for adult setting, probiotic has got very limited role. Second thing, anti-motility. If there is no fever, no blood, no mucus, you can use anti-motility agent. But in the presence of fever, the presence of blood or mucus or more amount of stools, don't use anti-motility agents before giving antibiotic. So shit happens every day. We know the differences and how to deal with it. That's more important thing in acute gastroenteritis. My other last one case. This lady is presented with cellulitis. Basically, it's very difficult to show. I put the wrong slides. Okay, fine. So the patient has got 50-year-old female, bilateral leg swelling of 7 days durations, but no tenderness. If you see, the redness is present for quite some time. It's not going rapidly. It is slowly and steadily is increasing. It's not rapid increase. So what do you think? Skin and soft tissue mean I don't run this poll. So we need to learn a lot. We need to differentiate. Sometimes what happened, patient always confuses with cellulitis with non-stasis condition, particularly patients has got venous ulcers or patients has got varicose vein. This type of stasis can happen. Usually bilateral, don't put your money on cellulitis. Cellulitis, most of the time it's in unilateral. That's more important. And second thing, what is the progression? This lesion is existing for quite some time, more than 7 days, more than 10 days, more than a month. That is not cellulitis. Cellulitis won't stand in a long-standing time without treatment. So we need to know whether the patient has got severe infections, how to say severe infections, neutropenic host, patients use IV drug abuse, the lesions can progress. And a patient is stable, what criteria I'm using called ALT7. What is ALT? Asymptomatic, not asymptomatic, asymmetry. Only one limb is involved, either right limb or left limb. Patient's age above 70, WBC count elevated, heart rate elevated. If the criteria is present, we can justify to use antibiotic. Asymmetry,
Hello.
more than 70 years.
Good morning.
More than 70 years, more than antibiotics, WBC count elevated, you can use antibiotics. So last case before knee replacements, what antibiotic? The patient has got 10 to the power of E. coli, or what antibiotic will give for this person? Whether you want to postpone the surgery, last poll, please go ahead and run. 60-year-old diabetic posted for knee replacements, no urinary symptoms, but urine routine showing pustules and culture is going 10 to the power of 5. Only antibiotics IV. So what antibiotic are going to use for this knee replacements? Cefuroxime, cefazolin, piptazo, ticoplanin, none of the above. So what are you going to do for this man? So usually don't do test. If you do test, then only the problem stands. For example, the patient came for TKR, total knee replacement. Why there is a need for urine cultures? The patient has got no symptoms, no dysuria, no urgency, no fever. All 4 criteria absent. So it has got very good negative predictive value. The chances of UTI is almost 99% ruled out. So there's no need to think about, I'm going to put a prosthesis, this is going to infect it. If you start using antibiotic, the resistance keep coming up. Similarly for dental, people want to give 2 days before dental procedures and country. If you got infections, gum abscess or something, yes, fine. Treat the abscess, drain the abscess. But when a patient comes for some dental procedures, why you are using antibiotic? Try to avoid antibiotics. Only the patient has got endocarditis or patient has got underlying structural heart diseases, congenital heart diseases, yes. Otherwise, dental prophylaxis also not required. Keep in mind. So, in summary, right syndrome. That's most important. Before write antibiotic and OPD, write syndrome. And syndrome, which syndrome does not require antibiotic? Respiratory tract infections, gastroenteritis, you can wait and watch provided the patient is stable. What infections? Urinary tract infections, meningitis, yes. And skin and soft tissue, progressive, yes. But we need to send appropriate sample before starting antibiotic. Third thing, what antibiotic? Spectrum. Anaerobes means what are all the antibiotics? Gram positive, what are all the antibiotics? Gram negative, what are all the antibiotics? Pseudomonas, what are all the antibiotics? So think about it, whether this antibiotic has covered gram positive, gram negative, anaerobe, or it cover pseudomonas, it cover MRSA. If you know the 5 things, it's easy for you. Whether it cover gram positive, whether it's gram negative, whether it's anaerobe, whether it's pseudomonas, whether it's MRSA. Gram positive, penicillins, first generation cephalosporin, up to third generation cephalosporins can use. Gram negative, mostly third generations, or fluoroquinolones, or cotrimoxazole, or BLBLIs. Anaerobes, metronidazole, clindamycin, amoxiclav. Amoxiclav has got good anaerobic cover. Think about it. So we need to know what organism. Pseudomonas means we need to use fluoroquinolones or aminoglycosides. If you think MRSA means either clindamycin or linezolid. So if you know these simple things, it's easy for you to choose what antibiotic. Then most important thing, nitrofurantoin will work in the lab, but nitrofurantoin for pyelonephritis will not go. Amoxicillin will work for a streptococci, but amoxicillin penetration to the brain won't be great. So we need to know whether the organisms, whether the antibiotic will reach particular site. If you think the patient has got infections in the brain, AMPI is a better choice, not amoxicillin. The patient has got upper UTI, cotrimoxazole, fluoroquinolone, provided it's sensitive, is a better choice, not the thing. For typhoid, the best choice is any antibiotic except fluoroquinolone, because fluoroquinolone resistance is very high. So we need to know the pharmacokinetics, whether the drug will reach the site, what is the resistance of the drug. For example, the fluoroquinolone to the typhoid, almost 90% to 95% is resistance. Keep in mind. Then we need to know the dose. Pediatricians is damn good. They write milligram per kilogram. Cefotaxime means 100 to 150 milligram per kilogram of the body weight. Ciprofloxacin means 10 to 15 milligram per kilogram of the body weight. Always goes with milligram per kilogram of the body weight. It's easy for you to choose. So for example, cefixime, 400 milligram BD is a minimum dose for adult. Don't write 200 milligram BD. Similarly, ciprofloxacin, 750 milligram BD. If you want to use cefotaxime, 2 grams IV TDS or 2 grams IV Q6 also, you can go for meningitis. Use proper dose based upon milligram per kilogram of the body weight. And short is sweet. Always the thumb rule, any infections, 5 days is fine. OP setting 5 days, IP setting 7 days. That's the rule I can say. Minimum 3 days. If you got guts, use 3 days. If it's an ordinary person, 5 days is fine. For IP setting, not more than 7 days. Keep in mind. So how to go about it? Infectious disease specialist is not available, but you need attending FeFCon 22, 23, 24. You can learn a lot, and we need to learn in short, because you're waiting for 1 year is a bit difficult. Yes, the other option is a tele-ID, and tele-ID teaching is also possible. We can teach you very busy schedule. Yes, we can teach you. If you don't want to learn these things, just call. We give the options for you. Just make a telephonic call. We give the answer to you. So telemedicine based training is also possible, and telemedicine based virtual training also running. A lot of hospitals joined in tele-network. They just call us the infections. For example, Southern Railway hospitals. One of the hospitals and private medical colleges hospital started. Suppose if you are working in a hospital, your hospital is interested in participate, please feel free to call us. We'll provide the number to you. Please feel free to call for your antibiotic support. Suppose if you are not confident, if you want to get a second opinion, yes. If you do antibiotics, your patients walk back vertically. Your patients walk back vertically, and there will be no lawsuits for you, so that you can retain your money, hard-earned money. Otherwise, one lawsuit will take crores and crores of money from the patient's lawsuits. Please be aware the medicines cause side effects. So I think FeFCon what is look at the paracetamol or dolo compared to antibiotics. That's not my aim, but avoid antibiotic. That's my aim there. So try to avoid antibiotic. That's a mantra I'm conveying it. So my last question is, do you interested to joining hands-on training on ID? This is my sake. I need to see the results in person for me. So please run the show. How many want to join hands-on training? Yes, no, only virtual. Later, I'm thinking. I like to see the response.
Please post the poll. Since till they are doing, sir, I can give you the results of the earlier polls. Sure. The earlier one, you had asked for that erythromycin and the options which we finished. There was another option. Yeah, please.
Medicine.
Yeah.
Which is
Yeah, he is showing, sir. He is showing, right.
Very good. Okay.
Can you show? Yeah, next one. Where was one more poll?
Which antibiotic? Why no antibiotics? Very good. So all the polls very good. So 25 no comorbid.
Last one, can you put somebody? Sir has given the last question.
Who is suffering UTI? Very good. So we'll see a little later. Last questions you can put. How many want to join ID? Okay.
Yeah, he will.
Okay. Last one. Okay, thank you. So what I need to do now, yeah. So those who are interested, please feel free to contact us. Those who want to learn, for example, our startup has started giving training for 2
Not
years.
this. Can you put the last one, please? Last one.
We'll do the discussion side. Let him see the no issues.
Yes,
so those
yes.
interested to learn 2 years program, fellowship in infectious diseases, yes, possible, but it's all hands-on. And people interested in MBBS, whether I want to go straight away for super specialty is possible. People want to learn antibiotics, stewardship alone is possible. All possible. Thank you. I want time for I started at 9:05, so almost last 7 to 8 minutes I keep discussions there. I hope I try to simplify the antibiotics to say no antibiotics in OPD. Please go ahead and ask, shoot your questions to me. Thank you for the wonderful opportunity.